In Hematology series. This time we have a lecture by an eminent speaker, Dr. Naseema Gangat, who is a professor from the Department of Hematology, Mayo Clinic. JAK2 unmutated erythrocytosis is a clinical dilemma which all of us face in our routine clinical practice. Patients very often come with polycythemia, majority of them who are asymptomatic, and once we evaluate them and rule out an MPN, how to proceed further, whether these patients required antiplatelets, whether they require phlebotomy, any role of hydroxyurea, and how do we evaluate and arrive at a diagnosis. Very often the patients ask, is it persistent, is it genetic, is it familial? And many times we don't have an answer. So we have a very eminent speaker who would enlighten us on the diagnostic approach and evaluation of patients presenting with JAK2 unmutated erythrocytosis. We are happy to have Dr. Naseema Gangat with us. She is an associate professor of medicine from the Department of Hematology, Mayo Clinic. Dr. Naseema has completed her internal medicine and hematology training before joining Mayo as a faculty in 2012. Her clinical interests include research on myeloproliferative neoplasms. She has co-authored over 100 key clinical papers and has contributed significantly to this field of MPN. She runs a lot of trials in this field, which has helped improving prognosticating and developing new medicines in the field of MPNs. Dr. Gangat currently serves as an associate editor for Blood Cancer Journal. It's a privilege to have Dr. Naseema with us today. And I thank all of you, both national as well as international faculties, for joining for today's webinar. It's also a privilege to have Dr. Emmanuel as a faculty here, who's an honorary consultant at the Department of Hematology, Nizamiye Hospital, Abuja. He's spearheading the myeloma and lymphoma program at Abuja Hospital in Nigeria. It's our honor to have him also with us as an elite faculty. Before I hand over the screen to Naseema, I would also like to invite all of you for our upcoming webinar on the 19th of July, 2024, where Dr. Uday from the Department of Stem Cell Transplant at MD Anderson would be speaking to us on challenging situations in acute GVHD. Over to you, Dr. Naseema. We would love to hear from you regarding your diagnostic approach to JAK2 unmutated erythrocytosis.
Thank you so much for having me. It's a true pleasure and privilege to be on this forum. And I'm just going to go ahead and share my screen. I think my screen looks okay. Yeah. Does the screen look okay on your end? Hi, can you guys hear me?
Yeah.
Okay, I'm going to go ahead and get started. So the topic today is a very interesting and a vast topic. So in the next 30 minutes or so, I'll go through the data for each of the JAK2 unmutated erythrocytosis entities, and then I'll leave ample time for your questions, which I did receive ahead of time, which is nice. I can go through each one of them and also take some more questions if we have time. So the outline of my presentation, I'll go through a couple of illustrative cases to kind of lend context to these entities. We'll go through the approach to JAK2 unmutated erythrocytosis systematically, going through the congenital causes, the acquired causes, and the nebulous idiopathic erythrocytosis. And then finally, we'll go through the therapeutic approach for each of these and come up with a few take-home messages for today. So these are real cases that came through our hematology clinic. So this is a lady I had consulted on, a 48-year-old Caucasian lady who was undergoing a kidney donor evaluation and was noted to have a high hemoglobin and hematocrit. When we looked at her prior counts, even 2 decades ago, the hemoglobin and hematocrit were high, very generous hematocrit of 58. Medical history was significant for hypertension. Her mother and brother were also noted to have erythrocytosis, so there was a strong family history as well. Her white count and her platelet count were normal. So going through the evaluation, I've kind of broken up this algorithm piecemeal so we don't get confused since there's so many entities. First of all, what triggers the evaluation of erythrocytosis? We usually go by the hemoglobin and hematocrit thresholds that have been set for the diagnosis of polycythemia vera, since that's the first entity that we have to exclude before we get to the JAK2 mutated erythrocytosis. So that's a hemoglobin greater than 16.5 and greater than 16 for males and females respectively, hematocrit above 49 or 48 for males and females. And just to let you know, the reference ranges may vary based on ethnicity, location, if they're in high altitude, so that and the sex of the individual. So that is to be kept in mind whenever we are evaluating an aberrancy in the hemoglobin and hematocrit. The screening for JAK2 is easy. It's on peripheral blood, exon 12 through 15 mutation screening, so that you don't miss the non-V617F variants, which are located in exon 12 or other atypical JAK2 variants. And once that has been ruled out, we need to look through the prior counts, long-standing duration, family history. That would kind of tip us over to the side of, is this a congenital or hereditary erythrocytosis? So as the case illustrated, there was a strong family history. Even prior counts had been abnormal. So the evaluation was taken for hereditary erythrocytosis. If the EPO level is subnormal, then EPO receptor mutations have to be ruled out. That is otherwise, for the other entities, the EPO would not be subnormal. If the EPO is normal or increased, then the differential rests on, is this a high oxygen affinity variant? Is this germline mutations in the oxygen sensing pathway? So the serum EPO level is another very key test. Unfortunately, the serum EPO level can sometimes fluctuate if the patient has had prior phlebotomy, so it may not be very easy to diagnose the patient if they've come after having had phlebotomy, but at least it gives us some idea which direction we are headed. Because we have to perform testing in a cost-effective, performed in a entity that further testing is pursued. And so subnormal EPO goes to EPO receptor mutations. If the EPO is normal or increased, there used to be the P50 evaluation at the Mayo. Unfortunately, we have replaced the P50 evaluation. We no longer perform it because there were issues with the machine. So I know there are other centers that may still be performing the oxygen dissociation curve. That helps distinguish, is there a left shift of the dissociation curve? Because that would point towards high oxygen affinity variants or other rarer entities. If it is not abnormal, then we need to consider germline oxygen sensing pathway mutations such as VHL, HIF2A, PHD2, and EPO mutations. At the Mayo Lab, we are performing HPLC, a capillary electrophoresis, and mass spec to diagnose high oxygen hemoglobin affinity variants. And between these three methodologies, we're able to capture all the variants. So even sequencing is not done in all the cases because sequencing could miss the rare polymorphisms. So we'll go back to our case. Her EPO level was subnormal, and it kind of went with her clinical history and family history. EPO receptor mutation was identified in exon 8, and we recommended optimal blood pressure control with lisinopril, low-dose aspirin, and routine phlebotomy was not recommended. She was not symptomatic. However, we were considering that prior to kidney donation, it may not be a bad idea because the hematocrit was in the late 50s to kind of at least bring it down to below 55. Since the data is quite, there is no set data on what the hematocrit threshold should be, whether it should be performed or not, but at least in the setting of a procedure, it seemed like a reasonable recommendation. And then we go to the next case, which is a 17-year-old, a young patient who had a lot of non-specific symptoms which led him to clinical evaluation: nausea, vomiting, abdominal pain, weight loss, cold hand and feet, palpitations. And the only abnormality that was found on his blood work was this erythrocytosis, which was so-called unexplained. He was a non-smoker. Physical exam was not revealing. And looking at his lab values, his hemoglobin and hematocrit were generous, hematocrit of 52.4. EPO was actually inappropriately high at 22.6. So in this case, we were more looking for acquired causes, even though this is a younger patient, based on kind of the clinical presentation, the lack of a family history. Hereditary erythrocytosis evaluation was pursued. That was unrevealing. It's always good to kind of rule it out, even though your clinical suspicion may be low. And then for the acquired causes, it is wearing the internist hat. We have to take a very systematic H&P, look through the medical history, looking through the medications. Is there evidence of cardiopulmonary disease, screening for sleep apnea? at the bare minimum, I do perform an overnight pulse oximetry as a screening for sleep apnea and abdominal imaging to make sure there are no renal or hepatic lesions. So that's the bare minimum. And then dictated by what other symptoms the patient has. For example, this patient had headaches, so we ended up assuming MRI of the brain as well. And based on the hemodynamics, pheochromocytoma was ruled out. Cardiac evaluation was undertaken with a shunt study to make sure there was no congenital cardiopulmonary disease that had been undiagnosed. And then, of course, if the EPO level is considerably elevated, we have to think about EPO-producing tumors, usually not marginally elevated. In renal cell cancers, the EPO level is quite high. So that would give us a clue that there could be a paraneoplastic phenomena going on. And renal cysts could be a common cause to a renal artery stenosis, specifically if a patient has uncontrolled hypertension. And then I put some rarer entities at the bottom, such as the link SH2B3 mutations, in which the EPO is subnormal, and the Tempe syndrome. There are few syndromes in which you can have erythrocytosis, such as Poem syndrome. In female patients, myomas, uterine myomas, and sometimes when they are in the reproductive age, they do not have the erythrocytosis because of the menorrhagia, but after they reach the postmenopausal phase, you may see that that gets unmasked. So this patient had the whole workup that I just alluded to. Bone marrow aspirate biopsy was also performed because he came from another facility and they were very concerned that maybe they don't want to miss out an MP. And even though the role of bone marrow biopsy, if the EPO level is normal and the JAK2 exon 12 through 15 peripheral blood screen is negative, is very limited. And I usually do not recommend performing a bone marrow biopsy for non-clonal erythrocytosis, unless there is a high clinical suspicion based on the clinical features, if there's a thrombosis history, if there are hallmarks of PV on the history. So in this patient's case, we did an MRI of the brain, and actually we found these cerebellar hemangiomas and multiple venous abnormalities. And even though we could not prove that that was the cause, we felt that that may have been producing some ectopic EPO production and leading to the erythrocytosis. Surgical intervention an opinion was taken from the neurosurgeons, but they felt it was not feasible because there were quite a few abnormalities and we didn't want to put him through an invasive procedure just to prove the diagnosis. So he was initiated on phlebotomies, and actually that really improved his symptoms because he had a lot of symptoms, this patient. And then the need for phlebotomies was determined by symptoms rather than a hematocrit value. So he was getting phlebotomies about once a month, and then he has been doing fine. He was able to get back to college and get back to his routine because when he presented, he was essentially non-functional with all the symptoms associated with erythrocytosis. So we'll go to the next case, a 66-year-old lady who has a few medical issues as highlighted above. Once again, referred for evaluation of erythrocytosis. Hemoglobin and hematocrit were generous, and there has been a progressive increase in her hemoglobin when we tracked down the prior values. Family history was unremarkable, no prior thrombosis. She had severe headaches and fatigue, and physical exam just had hypertension. So once again, just to let you know, we would complete the whole workup, even though in this patient, we're more towards the acquired spectrum. There was no family history and didn't look like there was a very long, it's not like we knew if she had elevated counts since childhood. But still, it is good to do the systematic workup, evaluating for hereditary causes plus all the acquired causes. And basically, we did all the workup and we didn't find anything. Basically, everything was negative. Even an expanded NGS panel, we have expanded erythrocytosis, idiopathic erythrocytosis evaluation to include variants that have been newly described. And even those were negative. And a working diagnosis of idiopathic erythrocytosis was established. Because of her symptoms, she did start on phlebotomies, which helped her headaches and her hypertension, and also aspirin 81 milligrams daily. So we're going to go through the field, a little bit of the history of the discoveries in relation to study of erythrocytosis. So EPO receptor, first of all, the regulation of erythropoietin production is through the HIF-PHD-VHL pathway. I'm not going to go through that pathway. I'm just going to assume that most people are familiar with it as they're studying erythrocytosis. But some of the key timelines at which discoveries were made: in 1993, EPO receptor mutations were first noted and described. Then in 1997, the VHL mutations were described in a region called Croatia, and then subsequently in areas of Italy. And then the PHD2 mutations were noted in 2006, and HIF in 2008, and in 2018, EPO mutations. So these are all mutations, germline oxygen sensing pathway mutations that have been known. And of course, there have been refinements over time, and as the technology is improving, especially with respect to HIF and ELGN, there were newer publications over the last year that they describe more variants which had not been previously known. And the EPO receptor mutations are gain of function, the VHL, PHG loss of function, the HIF is gain of function, and the EPO is gain of function, just for people to keep in context. And that kind of goes with how the regulation of EPO production goes in the pathway. So it never hurts to repeat. So once again, we start with the serum EPO measurement, and that kind of serves as the branch point here. So if EPO is subnormal, definitely in non-PV cases, EPO receptor mutations, the link SH2B3 mutations need to be considered. And if EPO is normal or increased, then if we've ruled out the hereditary causes, we have to make sure we've systematically looked at the medical history and looked at the medications to, just to rule in or rule out the possibility that it is acquired through something that's easily fixable. COPD, cardiopulmonary disease, those are some of the known causes. If a patient is a smoker, then the possibility of a paraneoplastic erythrocytosis, specifically with renal cell cancer, needs to be considered. And a few rarer entities, when you do the full evaluation and you still don't have a cause, is looking for even stuff like hereditary hemochromatosis. HFA mutations have been described, particularly if your patient has elevated ferritin, increased transferrin saturation. It's a good screening tool, and it can be done through the peripheral blood, the genetic testing. And I think after this workup is complete and we don't find a cause, then I think it is reasonable to presume that in this era, it is an idiopathic case. And as technology improves and there's more knowledge gain, it may need to be reassessed over time. So going through the connotations of each of these entities, specifically the hereditary erythrocytosis entities, these are fairly rare. So if you do a lot of tests, for example, at the Mayo Lab, out of 1,000 tests that were run, only about 10 to 12% had any abnormality on the reports. And most of them were actually high oxygen affinity hemoglobin variants for the congenital erythrocytosis. And amongst them, they were pathogenic variants, and some of them were variants of unknown significance, which we always have to wonder, is there any correlation? Whether they maybe because we phlebotomized the patient didn't mean that they had less thrombotic events. Actually, what mattered was if they were older, if they had cardiovascular risk factors, they were more prone to arterial thrombotic events, which is a counterintuitive information. And then a lot of these patients were symptomatic. Over half of the patients had non-specific symptoms. And for that, phlebotomy helped about a half of them, but in the remainder 30% or so, phlebotomy actually caused more symptoms because phlebotomy can lead to iron deficiency, it can cause dehydration, and it can also create a vicious cycle because if you deplete iron, then what you do is you lower hepcidin, and that can inevitably lead to increased erythrocytosis as well by increasing the availability of iron indirectly because it would no longer be inhibiting ferroportin. So this actually makes us question that we probably might be able best using phlebotomy for symptom control, not having a strict hematocrit, particularly not using the PV thresholds, which are very stringent at 45. And that may be a bit much. And in the guidelines, they recommend hematocrit of 52 for patients with high oxygen affinity erythrocytosis. And for the germline mutations, there is even less that is known. There were only 10 patients that have been seen at the Mayo. And of course, with 10 patients, it's difficult to say what the correlations were and what really helped the patients. But HIF mutations were associated with high incidence of arterial thrombosis. Actually, half of the patients out of the 6 listed here did have ART strokes and MIs, and they were on phlebotomy and they were on aspirin. And it has been shown in some of the other publications that phlebotomy itself may not help reduce the risk for thrombosis in these patients. With the HIF mutations, we also need to make sure they don't have concomitant neuroendocrine tumors or pulmonary hypertension, which needs to be monitored specifically to make sure if they have any symptoms associated with those. So this is actually a newer study from, it's a European collaboration where they studied thousands of patients with erythrocytosis and found 33 missense variants in a total of 43 patients in HIF2A. And they did try to correlate some of the clinical features for these patients, but unfortunately, if you look at the publication, there is more like functional data in silico analysis, but there were no treatment details provided. So it's very hard for us to know amongst these patients how they were treated or how, if anything, helped them. But medication-wise, a HIF2 inhibitor, which is already available for renal cell cancer, belzutifan, and for VHL syndrome, has been tried in patients with a particular syndrome called the Pasek-Zhuang syndrome, in which patient has erythrocytosis, headache, and a paraganglionoma, and was found to be effective in alleviating the erythrocytosis and symptoms associated with this, such as the headache. But it is not up for routine use. This was a case report which was published a while back in the New England Journal of Medicine. Going to the PHT2 variants, once again, this is the same group that looked at the HIF variants, which I've just presented in the slide earlier. And in this one, they compared the patients who had pathogenic variants versus those who had VUS. There was no difference in thrombosis. They did have some treatment data, which was good to see. At least a third of patients were treated with phlebotomy, and majority were on aspirin. And actually, 2 patients also received cytoreductive treatment, one with interferon and one with hydrea. And they found that a family history of erythrocytosis was most prevalent in those with the pathogenic variant as opposed to those with the VUS. So there is some kind of treatment data, but at least it didn't find any increased thrombosis in the ones with pathogenic variants versus VUS. And then for the CHU-ASH polycythemia, this is another very difficult entity because these patients have marked thrombosis rates. They are even more thrombotic than patients with polycythemia vera. And phlebotomy has shown not to be very helpful. In fact, phlebotomy increased thrombosis risk in one of the largest studies of 155 patients that was published. And they had tried to use ruxolitinib. Actually, there was a case series of 3 patients, which was published a few years back, which showed that there was symptomatic improvement in hematocrit control with the use of ruxolitinib in patients with CHU-ASH polycythemia. And then the EPO-R variant-associated erythrocytosis, once again, a newer report, which had 33 patients, which is a lot of patients because none of the other reports, most of them are case reports and case series, 22 adults. The majority, as you can see, were treated. There were only 3 adults who were not on treatment, and all the 3 patients who were not on treatment had some kind of thrombosis. And once treatment was started, there was no recurrence of thrombosis. Phlebotomy helped more than half of the patients with respect to symptoms, and it was guided by symptoms rather than a hematocrit value. And then I'll move to SGLT-associated erythrocytosis because these medications are gaining immense popularity in internal medicine, not just for diabetes, heart failure, CKD, and the indications keep increasing. And there are several medications that are approved in the US, and I'm sure there are some medicines available throughout the world. And the interesting part is that these medications cause erythrocytosis. And it often can be confusing because these patients who started out with a borderline hemoglobin hematocrit, they overshoot. And that makes everybody concerned to have they develop polycythemia vera. So we looked at 100 patients who were started on SGLT inhibitor therapy and developed erythrocytosis, which exceeded the WHO thresholds for the PB diagnosis, and kind of followed them and found that thrombosis was not very common. And most of the thrombotic events that occurred were arterial events, which are expected in this population of older patients, with the majority being males. And phlebotomy was used quite frequently in about a third of patients, antiplatelet agents in 2/3, and anticoagulation in about 16 patients. And we did not find any particular correlation between phlebotomy and thrombosis and the hematocrit level. And in fact, once the medication was stopped, the erythrocytosis resolved in the 16 patients where we had serial values. So I did want to bring this in the context of MPN because there have been cases where the SGLT inhibitor therapy may unmask an underlying MPN because patients get started on therapy. They may have borderline counts or hemoglobin and hematocrits that are not at the level where you would suspect PB or MPNU or anything. And then you start the medication, as in the cases highlighted here, and then they present with thrombosis. For example, patient number 1 had normal hemoglobin, hematocrit, white count, platelet count, and then presented with an MI with hematocrit of 60, platelets of 805, 12 months after being on SGLT inhibitor therapy. And then MPN diagnosis was made and was appropriately treated with phlebotomy, aspirin, hydrea, and the SGLT was continued. Then subsequently, 4 months later, gets a stroke. Hematocrit was 46, which was inadequately controlled for PB. So these are 3 cases out of the 9 that had unmasking of which suffered catastrophic thrombotic events. So it kind of tells us that, especially when we're using SGLT inhibitor therapy, and if the patients have any changes in the counts or there is a minimal erythrocytosis, not to assume that it is just because of the SGLT inhibitor, they should be screened for MPN. So we put together a few proposals that prior to initiation of SGLT, it is a reasonable thing to screen for MPN through peripheral blood testing, specifically if there is leukocytosis, thrombocytosis, or anything in the history that may make you think there could be an occult MPN or a masked PV case. And once you see the erythrocytes, definitely screening through the peripheral blood. And then if a mutation is negative, then it is reasonable to continue therapy and not necessarily discontinue SGLT inhibitor just because of the erythrocytosis, because it's not felt to be detrimental in terms of mortality. In fact, it is felt to be protective in terms of cardiac events. So going to the treatment algorithm. So first of all, as I mentioned, many patients have symptoms attributable to the elevated hematocrit. And if the patient is symptomatic, phlebotomy should be performed to see if it helps the symptoms. If the patient tells us that the symptoms are no better, then it is okay to stop the phlebotomies. There's no reason to continue and shoot for a particular hematocrit. So that is number one. If there are no symptoms and there's no thrombosis history, then it's best to observe these patients. We don't recommend cytoreductive therapy. Phlebotomy may be detrimental in certain situations, particularly patients with COPD, those with some of the congenital erythrocytosis with high oxygen affinity. There's a reason why they have the dissociation curve shifted so that they're holding on to oxygen. And if you do phlebotomy and reduce the hemoglobin and hematocrit, it could lead to more tissue hypoxia and worsen the situation for them. Low-dose aspirin is a reasonable consideration if they have cardiovascular risk factors. They should stop smoking and just, if they have sleep apnea, that should be treated. If they have had a venous thrombosis, of course, they need to be on systemic anticoagulation. And even with patients with a thrombosis history, phlebotomy prophylactically is not necessarily needed. It's best to kind of keep them on antiplatelet therapy and anticoagulation for arterial and venous thrombosis, respectively. So my take-home message is that this area is an evolving area with increasing prevalence. So there is a lot that needs to be learned. So the field, there is no set guidelines. So hence that leads to a very interesting discussion. And that is why I think this topic is very near and dear to my heart, especially seeing MPN, because these patients, MPN seems easy compared to JAK2 unmutated erythrocytosis. There have been several recent discoveries. They're looking for new mutations in the PHD2 and VHL. And EPO mutations were discovered about 6 years back. And then there's PIZO mutations. These are all very rare entities, but it's good to be aware of them, because if we don't screen for them, we're never going to diagnose a case. We have an expanded, highly sensitive NGS panel for idiopathic erythrocytosis cases, but that still is inadequate because we've only added about a set of 20 genes, some related to iron metabolism, the PIZO and EPO, and a few things that we didn't test for before on a routine basis. And the management really has to be individualized for these patients, with phlebotomy reserved for symptom control rather than hematocrit value. And the newer medicines, such as the HIF inhibitors, ruxolitinib, they look enticing through their mechanism of action, but they do require further study because you don't want to cause toxicities from these medicines in patients with a non-clonal disease, which is not a malignancy. So I'm going to put the reference for our review paper from last year, and this will be updated in 2025, which is coming up. I guess we're halfway through 2024. And I'm going to stop here. And I did put up the questions that Dr. Nikhil had sent to me by email, but I'm happy to take additional questions and we can go through these however you guys want me to proceed. Would you like me to go through these, or you want to have the audience ask a few?
Yeah, we can go through this as well. And there are a few questions which have come up from the audience also.
Okay, so I'll quickly go through these. How do you approach an asymptomatic patient with polycythemia in your clinical practice? And by polycythemia here, we're talking about non-clonal, basically not polycythemia vera. So asymptomatic patient can be simply observed. So there would be no role for phlebotomy. If they have cardiovascular risk factors, it's reasonable to give them low-dose aspirin. Otherwise, I think we we don't need to put them on cytoreductive therapy or do anything aggressive about it. Indications for doing a bone marrow examination in these patients: subnormal EPO level, and if the JAK2 screen was negative, it makes us suspicious that was the JAK2 falsely negative. So those would be cases where it may not be a bad idea to do a bone marrow examination. Otherwise, for non-clonal erythrocytosis, if the EPO level is normal or elevated and the JAK2 screen is negative, there is no role for bone marrow examination. In fact, it subjects the patients to unnecessary testing, but sometimes we do it to satisfy the patient and ourselves. The next question, how do you evaluate them once an MPN is ruled out? I think we went through the systematic evaluation. We go through, is there a family history, the duration of erythrocytosis, rule out hereditary causes. These are all blood tests, so they're easy to obtain. And then for the acquired, the testing, the minimum testing is screening for sleep apnea, reviewing the medications, and some form of imaging, at least chest and abdominal imaging, to rule out paraneoplastic causes. Then in this subgroup, what are the indications for phlebotomy? Any specific cutoff in terms of hemoglobin hematocrit? And I think I belabored that point too, that there is no specific hemoglobin hematocrit cutoff. We usually go by symptoms in these patients. And for procedures, I have sometimes gone with like 55 or 50. I think is just pretty arbitrary. There is British Society of Hematology guidelines which suggest hematocrit below 52 for hereditary erythrocytosis, and for COPD about, I think, 54 or 55, something like that. What is the role of thrombosis in these patients? We talked about that it is difficult to kind of assess directly because the case series are very small. And some of these patients are elderly patients, males with cardiovascular risk factors who would be predisposed to arterial thrombosis without antiplatelet therapy. So I typically put, if there's cardiovascular risk factors, the patient should be on routine aspirin prophylaxis. I do not see a role for hydria in any of these non-clonal erythrocytosis cases. What genetic tests do you do for understanding the etiology of polycythemia? I think we went through those as well. The JAK2 screen is to rule out PV, but then the other genetic tests are kind of mutation screens for hereditary causes. There's link SH2B3 mutation screen, which can also be obtained through NGS on the peripheral blood. How do you follow up these patients? And I think that's a very good question because it's non-clonal. Do they need to be seen in hematology? I usually follow up with them annually and see if they're on a very set phlebotomy program, or if they're asymptomatic, then they can be followed by their primary care physician. If there is new testing that comes about, like we did have a new panel that was rolled out a year ago, then it's reasonable to kind of run it on patients that we haven't tested if they were idiopathic cases. And I think there is no need for a very strict follow-up, specifically if they are asymptomatic. If they are symptomatic, then they can get their CBCs checked perhaps at the time of symptoms and then have a phlebotomy then to kind of see if that even correlated with the elevation in hematocrit. Role of HPLC in these cases. HPLC is used for the high oxygen affinity variant evaluation, and we have been routinely doing 3 tests: capillary electrophoresis, HPLC, and mass spec for evaluating the high oxygen affinity variants. So that would be something that would be considered, especially to rule out the congenital causes. Another very important question is, how do you correlate sleep apnea with erythrocytosis? And this is something we struggle with. Actually, the literature does not suggest a very high incidence of erythrocytosis in patients with sleep apnea. I reviewed a meta-analysis with over 3,000 patients, and the incidence of erythrocytosis in patients with severe sleep apnea was only about 6%. But they did suggest that treatment of the sleep apnea did lead to a reduction in the hemoglobin hematocrit. I've always struggled, like I don't know how long they have to be treated before we notice a difference in the blood values. But I think what is to be noted is that these patients are not at increased risk of thrombosis. So the elevation in hemoglobin and hematocrit is in no way detrimental. Syndromic association of young patients with erythrocytosis, another very important, not very common, but like I mentioned, Tempe syndrome would have a monoclonal gammopathy, perinephric collections, telangiectasia, so there would be elevated EPO level. So that would make you think of that. There's Poem syndrome with thrombocytosis and erythrocytosis. And in female patients like myomas, uterine myomas, and erythrocytosis are a syndrome. And I think for VHL syndrome, usually it's the erythrocytosis is paraneoplastic. For example, if the patient has a renal cell cancer, there may be ectopic production of EPO, and then it could lead to erythrocytosis. Role of the VHL mutation. I think the VHL mutation has been described most extensively in Croatia, a particular region, in Russia, and it is a very lethal mutation in terms of the thrombosis and early mortality. Most of these patients died fairly young of catastrophic thromboses. In fact, the thrombotic tendency was higher than PV when they could match these patients and studied them. And it causes erythrocytosis in two ways, actually, the VHL mutation. There's a secondary erythrocytosis because it inhibits the VHL-HIF interaction. So then you have increased HIF translocation into the nucleus, increase in EPO. At the same time, it also causes hypersensitivity to EPO by interfering with suppressor of cytokine signaling. So there is a tendency for like a primary erythrocytosis, a PV-like erythrocytosis with it. When do you give hydrea or do phlebotomy in congenital heart disease? Do not do hydrea for non-clonal erythrocytosis. And phlebotomy is also not encouraged in patients with congenital heart disease because it's a compensatory erythrocytosis, and it could be detrimental for these patients in terms of physiology. It could lead to more symptoms related to dehydration, iron deficiency, and create a vicious cycle. So I usually do not recommend unless the cardiology team would prefer a phlebotomy before a surgery or something. And then the final question on this slide, should genetic testing be done from peripheral blood or bone marrow? Peripheral blood suffices for all these evaluations. JAK2 testing, NGS testing, and everything can be done on the peripheral blood. I was in a meeting. Okay. Yeah. Yeah. Sorry for the interruption. Sorry, there was somebody at my door.
So I have a few more questions which have come up in the chat box. Can we go ahead with it?
Yes, please go ahead with it.
So Dr. Ranjit Matthew Varghese wants to know, how do you go around a patient who's on SGLT2 inhibitor, who develops a stroke and has a hemoglobin of 19? Is that an indication for stopping the SGLT2 inhibitor, or can it be continued?
That is a very important question. I'm glad somebody asked this question. Personally, I would stop it temporarily, at least to get the hematocrit under control and get the patient stabilized. Because if this is an initial presentation of an MPN, or even if it is not, it's good to abate it, get things stabilized, And then if it is a non-clonal erythrocytosis, and these patients are at high risk for stroke because of even the indications why they are on SGLT therapy, it may be reasonable to resume it later when things are more steady.
Dr. Nasima, why does SGLT2 inhibitors, why do they cause erythrocytosis? I mean, what is the mechanism?
Very good question. Again, it's also multifactorial. One of the key mechanisms is through HIF and increase in EPO. So when they study these patients, the EPO levels do increase, and they study the iron metabolism. It also interferes with hepcidin and the iron metabolism. So those are the two main mechanisms. Initially, there was a very simplistic explanation like, it causes hemoconcentration and the dehydration causes the relative increase, but that's not felt to be an important mechanism. So mainly through HIF and through hepcidin.
And serum erythropoietin level, EPO level, is an important investigation in the algorithm for evaluation. But very often it is not standardized, and different labs very often come up with a different report. So how do you interpret EPO levels? When we say subnormal, is there any specific cutoff that you are looking at?
I just I think you have to look at the lab reference range too. Like you said, that's important for all the testing. And I know I have data mostly for Caucasian patients, but your hemoglobin and hematocrit values for Asians might also be a little different because Caucasians have higher hemoglobin and hematocrit values. So I usually use less than 2. For me, is kind of like a low EPO, even though the reference range here is also like, the lower limit of normal is much lower than that. So that would tell me, okay, maybe this has been influenced by other things that have gone on in the patient, and I would still be suspicious.
And is EPO a sensitive marker as far as evaluating for an MPO is concerned? Because very often we have seen patients with an MPN also having a normal or sometimes even high EPO. So is it always necessary that the erythropoietin level has to be normal or subnormal? How sensitive is it as a marker to screen for MPN?
not a very sensitive marker, especially there's a lot of lab variation. So we rely on the JAK2 screen because, like you said, we have several patients with PV who have normal EPO level, usually not elevated, but in the normal range.
Dr. Srinidhi wants to know, during our genetic evaluation for JAK2 unmutated erythrocytosis, if we find clonal myeloid markers like TET2 or ASXL1, how would you interpret it in this scenario? In addition to, let's say, a VHL or a PISO.
In addition to?
A VHL mutation, if we find a clonal marker, if we find a clonal myeloid marker like TET2, how would you interpret it?
I would interpret it as clonal hematopoiesis, like a chip. This patient has VHL also, like there's a congenital erythrocytosis too. I'm getting confused.
In other words, there is a congenital erythrocytosis. There is a
and in addition, they have a.
if we have a clonal myeloid marker, how significant would it be in this setting?
I don't think it would alter the management, but it would be a clonal hematopoiesis. And as we start checking NGS on these patients, because these are all older male patients, typically they are going to have the chip, the DAT mutation, the DNMT3, SXL, TET2. So I don't think it would change how I label them. It's not like you would call them PB because they have a TET2 or, it would just be chip-associated erythrocytosis.
And Dr. Anusha wants to know, I think you've already answered this question. When do you recommend phlebotomy in a patient with cyanotic congenital heart disease, especially if the patient is symptomatic or if patient has an uncorrected cyanotic congenital heart disease?
I think I mentioned for these patients, if they are symptomatic, it can be tried, but gentle phlebotomy. You don't want to, because first of all, the hemodynamics wouldn't tolerate the regular phlebotomies, and you don't want them to get low in volume and iron deficient. So I am quite cautious. I talk very closely with the cardiology team, and perhaps smaller 100 cc blood removal based on the symptoms and seeing if it helps the symptoms at all. Or you could say, well, the symptoms are coming from other things too, because it may not all be the hematocrit. It's difficult to always document the cause and effect. And if they're having a surgery, I think I use kind of a rough, like keep it below 55, because some of these patients have very high hematocrits above 60 or so, sometimes even 65, 70. So it's good to kind of shoot for mid 50s for a peri-procedural situation.
And one more question from Dr. Srinidhi. Can HIF-IHC serve as a surrogate for a possible VHL mutation for those patients who have had a bone marrow test, especially in a resource-constrained setting where not everybody can afford an NGS?
Like a HIF-IHC?
On the bone marrow specimen, can it serve as a surrogate for VHL mutation?
I mean, I would have to, I'm not entirely sure. I don't want to misspeak and mislead the audience here because I think it would need to be discussed with the lab people who develop these testing. This another point I would like to see is like a lot of the work on the JAK2 unmutated erythrocytosis is in collaboration with our lab directors because, they know these assays, what are the shortcomings, what is, what I'm saying? They do the hereditary erythrocytosis in reflexive manner. So I'm not entirely sure if that would be sufficient since we are not using it here.
And one more question from the audience. I think, again, this is something which you have covered in your talk. Is there any particular cutoff for different mutations? Would you say 50, 55, or is it just based on the symptoms alone?
Just based on the symptoms. I think because we know that the elevated hematocrit here in most of these situations, as I reviewed in my presentation, don't really correlate with thrombosis. So we're doing it as more for the patients to feel better rather than try to reduce any thrombotic risk.
Other than CHUASH polycythemia, which you mentioned, are there any other subgroup of patients who are at a higher risk of thrombosis?
So CHUASH, the HIF patients are also at a higher risk for thrombosis in particular. And for the PHD2, the data is like not very clear because the number of cases studied have been very limited. And the EPO receptor data it looks like from the recent paper that was presented by the French group in the Hematology, there may be a higher risk with EPO receptor mutations. So I think among those, I think there is, for the HOA variants, I'm not entirely sure because first of all, the dissociation curve shifting is compensatory to make sure oxygen reaches all the organs. So that's more of a physiological phenomenon. The germline mutations, I think, are more likely to predispose to thrombosis.
And you mentioned there is no role for hydria or cytoreduction in patients with a non-clonal erythrocytosis. But if we have a patient who does not tolerate phlebotomy or who's intolerant, can hydroxyurea be used in such a patient to reduce the requirement for phlebotomy?
Definitely, if they need phlebotomy, they're symptomatic, and if we have no way out, I think it's not like an absolute no, but I haven't had to thankfully prescribe it. But there has been a small study looking at hydria use in congenital cyanotic heart disease. There were 4 patients. It helped them, but they got side effects and myelosuppression. So hydria also has side effects. So it will all depend on, is it benefiting the patient? Then, of course, sure, it's never an absolute no, but not necessarily like a preferred recommendation.
And other than this, is there any role of interferon in this group of patients?
I have not had to use, I don't think I read any literature on interferon use. I mean, I guess if you're talking about cytoreduction, they're all kind of in the same group of medications, right? Hydria, where they use interferon, interferon are injections. So, I mean, that's the thing with the hydria as a pill. It's easier to titrate because interferon builds up over time. And I did review the data on ruxolitinib use, right, for CHUVASH polycythemia. So there were 3 cases that have been studied. So that can also bring down your hemoglobin and hematocrit nicely because we know it causes anemia. And then I think the HIF inhibitors, I haven't personally used it, and I don't practice oncology either. So I don't know about the practical side effect profile on whether that would be, how you weigh the risks and benefits and decide if it would be beneficial to the patient.
And you mentioned other diagnostic algorithm in an asymptomatic patient, but practically, if a young male patient who's otherwise having no symptoms comes to you with a hemoglobin of, let's say, 18.5, how much would you evaluate? Would you just follow up serially, or would you go all the way and do the evaluation completely?
Like an asymptomatic patient, I would look at the prior counts. Okay, I would see if they run at that level, like you said, it's a healthy male patient, maybe that's their normal, maybe 18.5 is a normal. But if there is a change from the normal, like over the years, then I think even if they're asymptomatic, I would proceed with the evaluation because some of the entities are remediable, especially the acquired causes, right? So you don't want to miss out on something which is straightforward, like an untreated sleep apnea, and not treat them because that may have consequences too, right?
Exactly. So it's mainly dependent on the clinical scenario. And if it is persistent, you would probably go ahead and evaluate them to find out the cause.
Exactly.
I think we have come to the end of all the questions. Thank you so much, Dr. Naseema, for the excellent lecture and the question and answer session that followed it. You have answered all our questions as well as the questions from the audience in a very lucid way. Your lecture provided a lot of clarity on this otherwise confusing clinical scenario. So thank you so much for sparing your time on a Friday morning and joining us and enlightening us on this topic. I also thank all the faculty members and all the delegates who have joined in. We currently have more than 150 people who have joined us from 7 different countries. So that's great, amazing audience. Thank you all of you for sparing your time and joining us for this lecture. I also thank the Emcure team for providing this platform where we had this in a relatively smooth manner without any hiccups. So Dr. Naseema, once again, thank you so much for joining us and enlightening us on this topic.
Well, a pleasure. Thank you. If you can share my email with the audience, I'm happy to take any questions by email too if they come up in the future. Thank you.
Absolutely. Thank you so much.